All agree and understand that calcification is a real problem for us, and though we do definitely have more tools than we had probably a decade back, and that's made life easier. And again, it's intravascular assessment that makes you see many things that you were not seeing earlier. We all agree and understand, and this is Gary Mint's slide of 1995, and I think we all agree that coronary calcium is not something that's picked up well on angiography itself, and then surprises that are often picked up once you do other forms of modality of imaging. And intravascular ultrasound is not just to look at things, it also has an outcome benefit. We know from meta-analysis that there's a 37% cardiovascular risk reduction and myocardial infarction prevention by use of an imaging that we can prevent. Calcified plaques are of different morphologies, and you can have an arc of calcium, you can have superficial calcium, you can have deep calcium, or you can have calcium that is mixed, both superficial and deep. And it's important for us to quantify whether the superficial calcium that's close to the intima or it's a deep calcium that's away towards the adventitia. And I think we are all aware of the calcified nodule, which has now become very much sort of relevant now, something that we all now classify as eruptive and non-eruptive. And you know that the eruptive nodules, though they have a good outcome in terms of an acute result, these are the ones that come back later on with a re-event, whereas non-calcified or non-eruptive nodules are sometimes difficult to treat acutely, but these are the ones that have a good long-term effect. Thin cap calcium is something that's not often visible angiographically, and you'll be surprised when you do an imaging to sometimes see calcium in these areas. The only good thing is that angiographic calcium, which is not seen, usually does not portend a very sort of deep calcium or a thick calcium, and usually is something that can be treated with balloon itself. We've had trials which have talked about the comparison of location of IVUS or OCT to determine the calcium thickness, and we can understand that thickness of a calcium cannot be determined by our IVUS because we see a blank space beyond the calcium area. But again, thickness itself is one of the parameters. It is not the parameter that modifies the plaque. There are more important parameters, one of which is to make sure that once you're doing a procedure and you're modifying your plaque, make sure that you see these post-balloon. We have to make sure that you see these fractures and you have this reverberation beyond the fractured sites. And that tells you that that's an area where the vessel is going to stretch and you've created adequate cracks. We have scoring systems that have been devised both for your, of course, the OCT, but then we also have IVUS guided scores which look at the circumferential calcium, which also look at the arc of calcium, looking at the calcific presence of calcific nodule and the presence of a vessel size. So anything that is less than 3 or 3.5 has a worse outcome. So each of this gives your patient a point, and anyone who has a score of more than 2, well, that is a patient where rather than balloon, you need to cross over to something in terms of other modalities of atherectomy. So 2 is the size where balloon only has a worse outcome. And this is a score that was predicted where you look at the angiographic calcium. If you have angiographic calcium and then if you do an IVUS and you get one of these scores of more than 2, this is a place where you probably just doing a balloon may not be sufficient and you need to consider other forms of atherectomy. Whether you use a rotational atherectomy or use orbital, I think all of us, we talk about showing these cracks and demonstrating a good opening prior to putting in a stent. And Arun's case also demonstrated that putting in a stent is not something that you to rush to before you've prepared your bed adequately. Just a few cases. Now, this is a lady where you can see that there's an angiographically visible long tram-track calcium in the mid part. And it's a huge dominant right coronary artery that is supplying collaterals to the distal LED. Well, this was crossed with a microcatheter, and then an IVUS was done. And you can see, well, for want of time, we've got some frozen frames there. And you can see that there's tight circumferential calcium there. Rotational atherectomy was done here. And you can see that we've used a guidezilla to get your balloons inside. So it was difficult to track and even your balloons inside. And one has to make sure that you have an adequate guide catheter support, often using your other guide backup catheters. We made sure that we are preserving all these branches, and then a cutting balloon was used there. And again, as I said, we have to demonstrate the cracks in the calcium, which is seen in the lower frame there. And this is the result that was obtained. This is the pre-procedure, and this is post-stenting with good stents. And we had a good angiographic acute result, which was again seen by an IVUS, where we made sure that you had a good MLA. And again, you can see here for one-term frame, again, you can see that in the longitudinal images, you can see that there's good stent expansion. Well, this is something that we call as rota regret. This is one of my colleagues who had started off a case where angiographically you cannot see too much of calcium in the right side. Looks a simple lesion. There's antegrade flow there. And then this was started off with a wire. Again, he had trouble getting a balloon in, and you've seen that there's a Guidezilla catheter that's gone in there. And he's managed to get in a small balloon there. But this is, as we say, a rota regret, where you can see that the balloon just does not expand. Managed to get another bigger size balloon and a higher pressure balloon. And again, the same thing, you cannot really, balloon dog bones in the middle part, and you can see that it just does not open up there. An IVUS was done, which again showed the circumferential calcium there, and we had to do a debulking with a atherectomy to debulk the calcium. And then you can see that the remaining part becomes easy. Your balloons are now opening up, and you can then get a good result with your stenting. Along with this, we also have used atherectomy with an orbital, and this is a case where an orbital was used. This was a patient with an acute coronary syndrome, just post a non-ST elevation myocardial infarction, and we believe that the orbital has a lesser amount of distal microembolization as compared to a rota, and therefore this was a case where an atherectomy was done with an orbital, and again you can see that the balloons expanded well, and you could get a good result. When you use an orbital versus a rota, I think patients where you have a large vessel, yes, orbital is preferred. The choices could be the same. You could use it in either of the situation. But one other thing, as I said, is distal microembolization is a little lesser when you use an orbital vis-a-vis a rotablation. This is another lady who has had a tight lesion in the mid part. Again, this is a patient where we used an IVL, and we are lucky to have the C2 IVL, which has 12 pulses, unlike the 8 pulses that is the conventional IVL that we had earlier. So we now have the luxury of delivering 12 pulses with the same balloon. And this is the pre and the post. And you can see that we've developed this calcium. The cracks have been there in the lower panel. And therefore, that makes the job of putting in a stent that much easier and simpler with a good result. Also, the take-home points would be that calcium lesions need multiple technologies, and they are mostly complementary rather than exclusive. So we have these terminologies of rota cut, where you do a rotablation and use a cutting balloon, rotatripsy, or an orbitotripsy, where you use orbital or rotablation and then use a lithotripsy balloon. Well, it is important to keep it simple. Make sure that you plan your steps of procedures, keep all your hardware ready, and make it available and then proceed. Calcific lesions rarely need to be done in ad hoc, so you don't need to rush and complete the procedure at that period of time. Imaging technology is essential for the safety and long term, and as Arun has shown already, we needed to use at all steps. There have been many guidelines which have talked about how to size it, and that has already been talked about by my previous speaker. So I'll end here for want of time, and we can take questions at the end of the session. Thank you.